Okay, so this is a recording of a presentation that I did a little earlier this year to talk to you a bit more about diagnosis and management of dementia. So what I want to do first of all is to just recap what we talked about in the last webinar. And that was where we helped you with a framework to make a diagnosis of dementia. And we talked a little bit about the 5 domains of dementia, which will help you to think when you're taking your history and examining someone, does this person meet the criteria for making a diagnosis? And so we talked about cognitive decline, functional decline, psychiatric symptoms, behaviour changes and physical decline. And if you remember, we talked a bit about it not being just about memory, so it's about people who might be misplacing items, they might be struggling with word formation or remembering words, they may struggle to follow a conversation, they may have social isolation, apathy, loss of concentration. Their functional decline affects their activities of daily living, and you really need to be quite careful in your questioning about this so that you ask what they were like prior to having, what were they like last year, maybe 2 years ago, and how have things changed? So people can still be doing their activities of daily living, but maybe not as well as they used to. Psychiatric symptoms, we talked a bit about depression and anxiety, which both predate and then coexist with dementia. And we also talked about hallucinations and some of the other behaviours that are associated with dementia, which tend to come sometimes later on in the disease, sometimes hallucinations very early, and so it's important to ask about them and recognise them. And then physical decline, which is more a later symptom of the disease, where people lose the ability to eat, drink, become incontinent, maybe bedbound, for example. And we talked a bit about the stages of dementia so that you can think a little bit about where somebody might be in their journey, and perhaps even use this as anticipatory guidance. So explaining to family what might happen next and what they need to be prepared for. This helps people to plan where they want to be cared for, how they want to be cared for, and make some arrangements so that when the time comes, when things are more challenging, it's a smoother process. We're going to use the stages to outline how to manage people with dementia as well, and also thinking about those domains that we talked about, thinking about how we can target those specifically in our management. So we'll come back to these later. So just a quick reminder that in order to make the diagnosis, you need the 4 inclusion criteria and the 4 exclusion criteria. So, as we said before, gradual onset of poor memory, worsening memory problems, failure of function, and some evidence of cortical dysfunction. And if you remember, we talked about writing down, asking someone to say as many words beginning with the letter P as possible in 1 minute, or naming as many animals as they can within 1 minute, or asking them to demonstrate a simple action such as brushing their hair or brushing their teeth. And then the exclusion criteria, so these are the things you want to make sure they don't have, which is delirium, any other organic disease, which is where your blood tests come in, and psychiatric illness, as we referred to before. Dementia can be associated with depression and anxiety, but you have to treat those as best you can before you make the diagnosis if they pre-exist. And this, if you remember, is that very helpful slide which combines both the stages and the domains into one pictorial image. And when you have a look at this, I always like to point out this end phase in stage 3 where all the lines cross over one another. This can be really chaotic and is often where people end up in crisis. And until recently, that was often when people would be diagnosed. What we're aiming for is to really diagnose people back in stage 1, so we have some impact to slow the rate of cognitive decline, and also allow families and the people living with dementia to plan for this messy stage. It still happens, but it's a much smoother transition if you know it's coming and people are alert to the signs and symptoms or the changes that might be associated with it. And therefore, management of this can be much better, and the patient or person living with dementia has a much better experience. So first of all, we're going to talk about Anna. So Anna is a 75-year-old widow who lives by herself, and she normally attends on her own. But today she's attending for her flu vax with her daughter, Sophie. Past medical history includes hypertension and osteoarthritis, and she's on perindopril and paracetamol. So normally we show a video here, but just because it simplifies it a little bit, I thought I would just talk through the case. One of the things you might notice is that she normally attends on her own, but this time she's attending with her daughter. So when that happens, you always need to think, is there something else going on here? Is there perhaps a conversation that the daughter wishes to have about Anna? Or is there some concern there that we need to elucidate? So it's always a thing that should pique your curiosity when someone changes the pattern of how they attend. And in the video that we normally show, it shows that Anna has started to forget to attend for her routine appointments. She's not picked up her perindopril for some time. The doctor who's speaking to her asks a bit about her activities of daily living, and she says that she's not doing her garden as much as she used to. And she's not really as involved in things as she previously was, although she is still managing to cook and clean for herself and manages day-to-day things. During this consultation, the GP asks if it's possible to take a collateral history. And it is so important to take a collateral history from our patients, because you only get one side of the story if you ask just the patient themselves. And often it is the spouse or family who have noticed things that perhaps the patient may not be aware of. So when you're asking a collateral history, it's also very important that you gain consent to do that from the person who's attending the appointment. And so it's as simple as saying, thank you, Anna, you've given me lots of important information there, but I wonder, is it okay if I ask Sophie a few more questions about why you've come in today? And most people will be quite happy with that. Some family members do find it difficult to disclose information about their relative in front of that person. And so it would be perfectly reasonable at this point to ask Anna to perhaps meet with the nurse who might perform some form of cognitive screening or further testing for you, perhaps check her blood pressure, whilst you gain some further information from Sophie, the daughter. And in this case, that's exactly what we did. And bear in mind, when you're just meeting someone for the first time, or they've come in recently with a problem, it can take quite a time to get this information. So you might not be able to do this all in one day, but be opportunistic. And if you have the time, if you have the ability to perhaps ask Anna to see the nurse for a few minutes while you can get some more information from Sophie, do it now, because it might be that you don't get that opportunity to see Sophie again. So the daughter remains with you, and so Anna goes through to meet with the nurse. And now we're thinking about what sort of cognitive screening might we do. Cognitive screening, as we said before, I think in the first presentation, is as it is. It's a screening test. So it helps us to add more weight to the diagnosis, but it doesn't make the diagnosis. So if you have somebody whose history really makes you think this person has dementia, but their cognitive screening test doesn't seem to be marrying up with that, you might want to get further information, perhaps from a neuropsychologist if you weren't sure. But it might just be that they can perform very well on the cognitive screening test, and there is genuinely some underlying cognitive impairment there from the history. So always bear in mind that these things aren't 100%, but there are a few that you can use. As we mentioned before, the KICA is evidence-based for Indigenous populations or Indigenous Australians specifically. RUDAS is one that is performed in the language spoken by the patient themselves. So often you need a translator to do this one, but it's something that was developed in Australia for non-English speakers, and it's well recognised and very effective. The MOCA is more of a pictorial cognitive screening test. The GP cog is a simple one, which does include the clock drawing and a few memory questions, as well as some collateral history. And then the mini mental is one that everyone is familiar with. I think we talked about the investigations in the last presentation that we did, but just to remind you, we are doing these just to exclude any of the exclusion criteria. And if you have a look here, you can see the exact reasons why we're doing the investigations that we're doing. One thing it's interesting to point out is that most health pathways actually have a health pathway for dementia. So if you ever need to be reminded of what I've talked about today, most of the information will be on the local health pathways. So you can always go on there if you want to have a reminder of what is going on. And we also offer a more in detailed version of this called Demystifying Dementia on Think GP, which is a free educational space for you to learn more about it. So I want to talk a little bit about the collateral history. And when we're doing a collateral history, you really want to be drilling down into those careful questions about how safe is the patient, how are they managing in terms of things at home. So when we talked to Sophie, it turns out that her mum Anna was leaving the gas on a few times, had burnt a few meals, and so there was some risk there with respect to that. You also want to be asking about things like driving. So does the person still drive? How safe do you think their driving is? And when you're thinking about screening for this kind of information, you really want to be finding out, has the person started to make any changes with regards to their driving? Driving is always one of those things that people find a real challenge with dementia, and that's because having a diagnosis of dementia doesn't necessarily mean you can't drive, but it means that you need to start thinking about, we refer to it as retiring from driving. And you can make some assessment as to how somebody is doing with their driving by asking them a few questions about driving. So for example, people will start to change the way that they drive. So they may now only do familiar routes of short distances. They may only drive when there's someone else in the car with them. They may only drive during daylight hours. They may avoid particular routes where the roadways are perhaps more difficult. So if it's a dual carriageway or something like that. And so if people are starting to do this sort of thing, that's an ideal time to suggest to them that perhaps they're already aware that their cognitive impairment is affecting their driving. And perhaps it might be time for them to start thinking about stopping driving. And talking to people from very early on in their diagnosis about this is helpful because it gets people to start thinking about it. And quite often people will rescind their driving license without much difficulty if you've had the conversation early on and prepared them for it. Another tool that you can use to help with assessing driving is something called the maze test. I recently recommended it to a colleague, and this patient who had a diagnosis of dementia always presents very well, is very good at communicating, and it can be quite difficult to find out, just in that conversive way, that he has a problem with his driving. So my colleague utilised the maze test, and which is where you follow as if you're doing a maze that's printed out and it's timed, and the number of wrong turnings you get or misunderstanding how to do it, or the time taken gives you an accurate assessment as to whether somebody is safe to drive or not. Anyway, this patient failed the maze test on several occasions. And so my colleague felt very confident in communicating that he didn't feel it was safe for this person to drive anymore. So that can be very helpful. The other thing that you can use for driving particularly is occupational therapy. And there are occupational therapists who will perform a driving assessment for you. So if you really are unsure, and I would quite often refer people to a driving assessment, because if somebody is very resistant to stopping driving, referring them on to an independent person who does that assessment can be quite helpful. And it means that if you're having trouble convincing them, you're then not breaking down your patient relationship with them. But an independent person has more ability to explain that sometimes to those people who are particularly resistant. So that can be quite helpful as well. And if you look up, you can find your local occupational therapy driving assessment centre. All of the rules as per the states are very different. So you need to also check your driving medical assessment according to the state-based areas that you work in. So when we're thinking about managing dementia, we think about it in terms of the stages. So if we think about stage 1 again, so stage 1 is when someone is still at home, they're maintaining their independence and enjoyment of life. And we always at DTA like to think of managing dementia by maintaining someone's dignity. Dementia as a disease can be very upsetting for people, and they often fear the loss of dignity that occurs as a result of the disease. So if we can make that a priority when we're managing patients, then we know that we're really putting that person at the centre of their care. So stage 1, maintaining independence and enjoyment. And if we think back to stage 1, we're thinking about short-term memory problems, repetitive questioning, for example, in terms of the cognitive impairment. And within this, if we're thinking about ways in which we can help people, it's with looking at their medications. Are there any medications that might be adding to that cognitive impairment? So reducing any of the anticholinesterase medication, the medications that cause more cholinergic effects. So we want to reduce those. Looking at whether or not we want to consider starting anticholinesterase inhibitors. Now, many people feel that that is something that isn't part of the remit of a GP, but if you have got a geriatrician whom you are in regular contact with and you feel able to discuss cases with them, then you are in most cases able to commence the medication. So it's not that they have to be reviewed by a geriatrician, they have to be discussed with, I think, in the PBS criteria. And even if you're not the one starting those medications, it's important that you understand how those medications work and the side effects that are associated with them, because patients may come to you with those side effects asking about the medications. So just briefly, when we are thinking about starting these medications, the most common one that we start is donepezil, and we start it slowly. So always starting with a very low dose, 5 milligrams to start with, and building up slowly. Advising people that the main side effects they'll experience might be headache and nausea, sometimes abdominal pain, but that these do settle down after the first 2 weeks. I always review people like you would when you start antidepressants. I review them after 2 weeks to see how they're getting on and warn them that they will get side effects, but that they usually settle down. It's important that you don't start these medications in people who have contraindications to them. And these include things like gut ulceration and people who have heart block, as well as severe asthma. Otherwise, there are very few contraindications, and so many people can use these medications. Whether they work or not, I'd say they probably work in about 30 to 50% of patients, but in quite a subtle way. So you will notice that relatives or even the patient themselves might say that their concentration is a little bit better, they're a little bit more switched on. Sometimes people say it's the light is a little bit brighter in that person, but they're not having any massive effects. And at this stage, we do not have any medications that will have a massive impact on slowing the rate of decline of dementia. but they're worth a go because there is some evidence and there isn't really anything else that we have in our armoury, with the exception of modifying cardiovascular risk factors, which is something that's proven to slow the rate of decline. So if we can be careful about managing blood pressure, cholesterol, activity levels, all of these things will help to slow the rate of decline. Another thing that you might want to consider at this time is also something called cognitive rehabilitation. Now, it's not really offered in primary care, but it might be something that you could seek out or at least let the patients know about. And it's where you do computerized brain training, if you like. Now, there are some particular ones which have evidence behind them, but many apps are available. And so even if it was just Sudoku or something that the patient was interested in, that focus and using your brain to really concentrate on things can help to slow down the effects of the cognitive decline. And that has just as much evidence as the medication. So it is something worth discussing with families. As well, at this point, we would also be discussing some of the legal aspects associated with dementia. So you want to think about, has the person thought about a power of attorney? Do they even know what a power of attorney is? Do they wish to have an advanced care directive? Explaining to the family how things are likely to travel in the next 10 years, things that they might be looking out for, giving them some good advice and informing them of where they can get further advice from should they need it. So practice nurses, general practitioners, Dementia Australia, perhaps the geriatrician, and you might want to consider having regular appointments with these patients so that you really are there as the contact person to pick up any changes as they occur, so you can be really there to support them if they need to have the next step of care, for example. As I've mentioned already, function, we're thinking about home hazards, driving assessments, family education, and explaining to people where they might get further support from. I've already mentioned the OT driving assessment. It's really important to help people navigate my aged care. The recent Royal Commission found that people just did not understand the process. It's really hard if you're not even that computer literate, but even if you are, it's quite confusing. I've logged on behalf of patients and it's just a mass of providers that's really difficult to navigate. So helping people log on and get their initial assessment so they're in the system. We know that waiting times can be really long. So as long as we've got them registered on the system and they've had an assessment, at least it will be easier to access later on. When we're thinking about the psychiatric symptoms, people can become really socially isolated, even at this early stage. And so we really want to be engaging people in social interaction, getting them into perhaps social groups, encouraging them to meet up for coffee with friends and family so that they're really engaging in other activities. There's no reason why people with dementia can't continue to do their normal activities, perhaps sports or bowls or something like that. But they need to be supported in doing that. And this comes through family education, education of other friends and relatives to show them where they might be struggling. So if they are having a problem, adding up the score in bowls, someone is there to support them and knows how to support them so that they don't, sometimes people fear the stigma or become embarrassed about things. And so having that support and education can really help people have a better experience. And then, as you would do in perhaps every over 75s check, you would do all of the routine things that help that person to maintain their physical fitness. So exercise assessments, nutritional assessments, hearing assessments, falls assessments, podiatry, making sure that people have really good senses, so making sure they've had their optometrist appointment and they can hear well can really improve their cognitive function. You don't want people falling over, so having good podiatry is important. And this really shows you how a GP management plan can be used within the realm of dementia. It's the perfect disease to incorporate all of these allied health professionals and regular reviews so that you're keeping on top of patients and they're not kind of drifting into the ether. So if we think about stage 2, Again, things have progressed a little bit here, so perhaps things are becoming more difficult in terms of completing tasks. Perhaps people need to enact the power of attorney now, so, you know, patients might be struggling with going to the bank. They might find it difficult to do some of the processes they've been doing before. So again, having regular meetings with them and making sure that they know how to do this might be helpful. We might also want to consider de-prescribing at this point, because there may be some other medications that we no longer need to use. And so when we're thinking about that, I like to use a tool called the Stop-Start tool. Now, this was developed in the NHS, and it's a really useful tool. So it's color-coded, green and red. In green are all the drugs that you should be starting in the elderly, and in red are all the drugs that you should be stopping. It's based on our British National Formulary, so it's in that order, but otherwise it's, you know, drug related, so it's quite easy to use. It's not just for people living with dementia either, it's for anybody over the age of 70, so it's really, really useful to have a look at that. And when you're doing your medication reviews or seeing your patients for their care plan reviews, really having a look at the Stop-Start tool to give you some ideas about what you should be stopping and starting. So again, moving down into function, you know, maybe people are having even more difficulty in terms of managing at home. They might need some home meals, perhaps, or some home help. So you might be making sure that My Aged Care is able to come in, pop in. They might be needing some support with their medication. So could they see the pharmacist to do dosset boxes? There are some gadgets for timers that dispense the medication at exactly the right time. And if the person doesn't pick it out of the box, then the phone call goes to the carer. So, you know, is that something that you might be requiring? There are also some more nifty gadgets that you can use. For example, watches now have GPS in them. They also have falls detectors. The new Apple Watch has an AF detector. So there are, you know, make use of technology and advise people about this so that they can use that as well. Again, making sure that when we're asking questions, we're thinking about the psychiatric conditions, hallucinations. If you don't ask about them, you won't know. And perhaps doing the geriatric depression score again to see whether there is any evidence of depression. Some of the stuff later on is repeated from the previous stage 1 GP management plan. And, you know, it's just about recognising that there are increasing care needs in stage 2. So moving on then to stage 3, things might be becoming more difficult in this stage. And this is when families need extra support. They may be having to think about whether or not patients or the person living with dementia needs full-time nursing care. They may have transitioned already in stage 2 into some form of residential aged care facility, but they may now be needing to go further on down the pathway into nursing. They could still be at home. They could have been not diagnosed yet and suddenly present when they're perhaps wandering out into the streets, inappropriately dressed. And so that, you know, that's a real urgent situation where people are putting themselves at risk. And so you might want to, you know, arrange an urgent meeting to discuss with family if that's the case. But there are some really useful people out there to support you if you're just not sure what to do. Psychogeriatricians and geriatricians can be helpful. If they really, you know, really are at risk, they might need for a time a short stay in a dementia unit, and that can be helpful just to manage some of the main issues that are happening. If they're at home and it's simple things that they're struggling with, perhaps sleep disturbance, then you can call the dementia support or DB Mass for advice. They're a 24 hours, 7 days a week call line where families, nurses, doctors, anyone really can ring up to get advice about behavioural changes, because it is really in this phase that we see those behavioural changes and they can be quite challenging to manage. Again, there's a lot of changes in physical needs, particularly incontinence, falls, lack of mobility, even swallowing and increasing in pain. Patients may be bedbound, they may be struggling to eat and drink, and it's important that we recognise that when we get to this stage, it really is the palliative care stage. So you want to be avoiding unnecessary hospital admissions, really stopping medications, rationalising medications that aren't necessary, and having some kind of advanced care plan or advice for either the nurses or the relatives about how things will be managed. So if someone gets a chest infection, you might treat with oral antibiotics, but that might be the ceiling of treatment, or you might not even treat with any antibiotics. You might just observe and do conservative management, or you might do supportive therapy in terms of managing pain, but not anything else. So it's really recognising that and opening the conversation, having good communication about it so that patients and their families are really aware of what's going on, because it's often the lack of communication where complaints and unnecessary hospital admissions occur. So as I said, we said at the beginning and through all of our presentations, we want you to remember that dementia is more than just a memory problem, that the screening tests are not diagnostic, and that management and diagnosis can take place in general practice. And as we see most of the patients with dementia in the community, it really is important that we have a good idea of how to manage those people. Seek out other support, so make sure that you do get support from a geriatrician, psychogeriatrician, Dementia Australia, and other support teams, but really it is up to us to really take charge and manage patients who are living with dementia in the community. Thank you for listening.